All right, so I want to welcome everyone to the space. Thank you so much for joining us for the Alameda County breakout. We are joined here by Public Health Director Kimi Watkins-Tartt, who is the Public Health Director of the Alameda County Public Health Department, and also joined by Dr. Noha Aboelata, the CEO of Roots Community Health Center, who's also a medical practitioner. We are so grateful to have you all here with us today. They're going to share some information with us, and then we'll have some time to actually have a dialogue and have some of your questions answered directly. So, with that said, I will turn it over to our experts.
Thank you. First slide, please. Um, Dr. Aboelata and I are going to speed through some slides so that we can get to the questions and answers. Next slide, please. So this slide really sort of recaps a little bit about what Dr. Burke Harris also mentioned in terms of how African Americans are doing in Alameda County as compared to the state, as compared to the United States, to the country. And what's important to know, for at least for our county, is that for African Americans, we represent 17.6% of the deaths, COVID deaths. And that was much higher than what was reflected for the state and for the nation. We are doing better in the area of vaccine. However, we have a long way to go in Alameda County if we are to come to percentages that are comparable really to the number of African Americans that died in our county. Next slide. This second slide is really just talking, showing specifically about vaccinations. And one of our epidemiologists recently did some new analysis for me for this slide. And so we are doing increasingly better in terms of vaccinating African Americans. And a lot of that is really due to a lot of the community work that is being done. Again, we are not going to rest on our laurels. We have a long, long way to go to get African Americans vaccinated, but we're pleased with the progress that we have made so far. Next slide. Dr. Burke Harris also talked about this, and all of this will be not important in a few weeks. This is who's eligible in Alameda County. And even so, even though we have the framework that we're following that's given to us by the state, we in Alameda County are still asking people to prioritize older adults, people who have Medi-Cal, who are uninsured, people who reside in locations that have had high case rates of COVID, and we identify certain zip codes in Alameda County and really ask that those zip codes be prioritized. We're also asking that people be prioritized if they have jobs that have them that are publicly facing, that they don't have the ability to work from home, or they have limited mobility. Next slide. In our county, our strategy is in two parts, and it's probably similar to what's going on in other counties around the state. Our healthcare providers make up a bulk of how vaccine is distributed, which is not uncommon and very similar to how vaccine is dispensed under ordinary circumstances. And so you see our partners, our Community Health Center Network, Roots Community Health Center, Davis Street, as well as the large pharmacies and so on and so forth. We also have three, actually, if you count the vaccine site that's at the Oakland Coliseum. That is a partnership with the state and federal government. We have three large mega pods, if you will. And then we have community pods or community efforts, which are pop-up sites, which are neighborhood-based sites, which are mobile, where we go to housing developments, go into people's homes, And so it's in this territory that we really are testing out a lot of different ways of reaching people. And although in these settings the numbers are not usually really high, they're smaller. What we see though is that the numbers, the percentages of people of color that we reach are much, much higher though, because we're able to be more nimble, and we're able to reach the people that we're trying to reach. Next slide. Our community pods, the way we are starting to roll them out, and what we're looking to do is to really do this in the format of a coalition. What we have learned from our testing work and from the Fremont High School pod is that none of it is successful without partnering with community organizations. Identifying people, reaching people, engaging people, helping them to sign up, all of that is really required in order to reach the African Americans that we are trying to reach, or the Latinx population as well. And so no matter where we locate a vaccine site or have a clinic, if the partnership isn't there, what our experience tells us is that it won't be successful. We may get people, but we will not be able to get the people that we are really trying hard to reach. And so we started a new pod this today, actually, Ashland Cherryland, and it's at the Hayward Adult School. And so the way that we're approaching this one is that we're starting it out. So we'll staff it. And we are hoping that through funded partnerships or funded with community-based organizations, that community partners will slowly, gradually take over the running of that site. And so we are looking to enter into those kinds of collaborations with the other community sites. It's something that we haven't done quite yet with a vaccine site, but we're excited about the opportunity and the possibilities. Next slide. I think this actually might be the last slide. Lessons learned. So I'm going to actually transition to, can you leave this slide up maybe? Okay, so I'm going to transition to and hand it over to Dr. Aboelata, and then the two of us together will talk a bit about the lessons learned.
Thank you for that, Director Kimi. So my name is Noha Aboelata. I'm the CEO and founder of Roots Community Health Center, and we are based in Oakland. We also have operations in San Jose. And we've really, we're a community health center that really was established in order to address health disparities for our community. We really put ourselves in a location where there's been long-standing health disparities that we can trace back pretty far back to, redlining, all of the structural inequities that have been created and perpetuated over the years. And so we sort of put ourselves there at the forefront and have really worked to be at the forefront in terms of this crisis. And so we opened the first free walk-up testing site in the East Bay back in April. And so kind of long before I think that they were really, well established across the county. And what we felt was important about that was, I think we've kind of been having this message since the beginning, like nobody's coming to save us. We have got to do this ourselves. And so we're going to have to build it by hook or by crook. And that's pretty much what we've done. So before we had the funding lined up or any of that, we just said we're going to have to do this because not only do we need low barrier access to these resources, but we need to understand what's going on, because there's a lot of confusion. Back then there was a lot of confusion, and there's still a lot of confusion. And the way that we cut through that confusion is by participating, gathering the information and the data that we need and lifting that up. And so that's sort of what we've been doing since the beginning, and really developing communications around what it is that we're seeing in our community. So how it is that we're catching it and transmitting it, and what seems to be going on, and then how do we relay that back to our community. So we created back in the summertime People's Health Briefing, which is every Tuesday morning, about 15 minutes. We just go over exactly what's going on in Oakland, in the most impacted zip codes, which of course is the zip code that we're in, as well as the ones directly surrounding us. So in that same East Oakland zip codes, the same zip codes that light up for every other disparity, unfortunately, are the same zip codes that are lighting up. And fortunately, with the state's framework around the HPI quartiles, that is lining up for us. And so that is a beneficial thing in the sense that it's being recognized that these are communities that are impacted by poverty and other structural issues that are requiring, that equity will require that we focus more attention there. So I think that that's a good effort. We'll have to make sure that that is executed properly. And I'll talk about that in just a second. And so I think one of the things that Director Kimi mentioned around the death disparity was something that was really lighting up for us very early on, like what is going on here. And the death disparity within Alameda County for African Americans has been almost double the average for everybody else. And so this is very concerning because we don't have very solid reasons why this is happening. I think we can, I think we can draw some assumptions, I guess I would say, but we don't have all the final conclusions about it. And it is looking much wider of a disparity than what we're seeing statewide or even nationwide, although there's other pockets that have tripled the death rate. And so we know that there's a lot of different factors at play that we need to better understand, but nonetheless, this is a fact. So African Americans are dying at almost double the rate in Alameda County from COVID than others. Having said that, the case rates are not particularly impressive, if you will. So within the Latino community, their case rates were very, very high, but their death rates are not as high. And so when it comes to thinking about what we have before us in terms of vaccination, I think the good news, as Director Kimi pointed out, we're doing a better job in Alameda County of vaccinating people of African descent, and we're doing better than the state by quite a bit, and better than the nation as well. But when we think about equity and what's going to be needed in the response, the way that we're thinking about it is that because the case rates have not been particularly high in our community, our natural immunity is low, right? This is a brand new virus. None of our bodies have ever seen this virus before, 2020, basically. And so if you have a community that had a lot of cases, so we've seen some areas in like in the Fruitvale area of Oakland or in Los Angeles where there were so many cases, then you have what's called natural immunity. And so the ability for it to spread is not as great. And the amount of vaccination you need to reach that herd immunity is presumably lower, right? But in the African American community, we don't have a lot of natural immunity because our case rates have not been incredibly high. And then you have a double the death rate. So those two factors taken together make the need for vaccination much greater. And so it can't just be that we keep up with the population rate or do just as good as others. No, we're going to have to do more if we're going to try to eliminate this death disparity that we're facing. So there's no doubt that the tiers have been challenging. I feel like it has my head spinning every day. There's every day there's some new thing and a new thing to try to figure out with the tiers. But there's some things about the tiers that have been inherently inequitable that I think is important for us to think about and call out. For example, one of our largest health system, Kaiser, was stuck in that 75 and up tier for quite some time. If we look at the life expectancy rate, it was less than 75 for African Americans before COVID. This past year, it has dropped dramatically now to a life expectancy of 72 years old. So only vaccinating people over 75 years old is inherently inequitable and not going to get us to our goals, as an example. Another example for me personally is something that has bothered me since the beginning of this pandemic is trying to understand how high blood pressure is an independent risk factor for doing poorly with COVID. It's very unusual for an infectious disease, right? Diabetes, yes. Cancer, yes. But high blood pressure, it just seemed automatically inherently unfair, understanding the burden in our community of high blood pressure and how if you have high blood pressure, somehow you are going to do more poorly with COVID-19. And high blood pressure is not on the tier list at all. And so in my opinion, it should be called out specifically because this is something that could help us overcome this death disparity. And so it's a problem because it requires a physician to say, okay, I think this person is at higher risk, and then go ahead and recommend them for the vaccine. But like Director Kimi said, hopefully in a few weeks, all these tiers will be a thing of the past and everyone will just be eligible. But since the beginning of the vaccines becoming available, and it will continue to be the case as far as Roots is concerned, is we are reserving our doses for our community as much as we can, because if we don't do that, we will get crowded out by others. We have seen it happen time and time again where folks with more access to, I don't know if it's just the technology, it's the cars, it's the bots and the scammers and scanners or whatever they call them, to be able to get appointments and or be able to, stay on top of that, to be able to get in there when there's an opening. That most of our communities is essential workers, don't have time to do all of that, are not going to do all that, and frankly aren't convinced they want to do this in the first place in some cases. But even for those who are ready to get the vaccine now, having these challenges with access. So the way that we've approached it, there's no better way I could say it than we've created like an underground referral railroad system to get to our site so that others can't get in there. And so we've really leaned on our partners that we work with in the community, that are working with the same community that we're concerned with, and making sure they know how to access our site. And it is truly a challenge. It's extra work to do that, but it's something we have to do. And it's the reason why, the vast majority of our vaccines are going to our community, as well as other communities of color that are at higher risk. And so I think with that, maybe we can go to some of the lessons learned. And I can just start with the first one, which is that, part of the reason why I founded Roots in the first place is because the healthcare delivery system and the public health system are so far apart. And I never did understand that. Going through medical school and understanding that the reason why people are sick or why they're not achieving wellness doesn't have as much to do with how many doctors and prescription pads and stethoscopes there are in a community as it does with so many other determinants of health. And public health understands those very well. And so there needs to be a bridging of those two. And I think that this pandemic has highlighted what I think a lot of us have known for a long time, is that the gap between the two is dangerous, and it weakens us. And even though, I would venture to say we have the premier healthcare delivery system in the world, people come from all over the world to come here to get, cutting edge treatments and things like that. When it comes to a basic public health infrastructure, we are faltering. And we see countries that we kind of have the nerve to call developing countries or this or that, kind of making us look bad in this pandemic, because they have that public health infrastructure built and it's connected to a delivery system. And what we've seen in this pandemic is that if you don't have that public health infrastructure, your healthcare delivery system can become overwhelmed. I don't care how great it is. If you don't have beds, you don't have ventilators, or you don't have room in your ICU, you are in a disaster. And we have found ourselves in the disaster of our time because of this. And so I hope that this is a wake-up call to us to understand that there needs to be more collaboration and coordination between public health and the healthcare delivery system.
I'll just kind of go through some of these really quickly, because I know that we want to go to the questions too. So another lesson learned was smaller. Smaller is better for us. That the larger sites can get a lot more volume, whether it be for testing or vaccines. But when we really want to reach certain populations, and the African American population has been a good example of that, we really need to have smaller community-based efforts where the people who are there look like us and they're culturally relatable. Also, we need to create meaningful opportunities like the people's health briefing, opportunities for us to talk and to dialogue and to address our concerns and to ask questions and to chew on things and think about it, about all of this. Our public health infrastructure, as Dr. Aboelata has said, really has to include and does include community-based organizations, faith-based organizations, and advocates as well. Eliminating unhelpful narratives. And what I mean and what we mean by that is that there is this thing, people are now vaccine hesitants. And I've been in public health for over 25 years. And what I can say in Alameda County is African Americans are not necessarily vaccine hesitant. We are not the community asking for the personal belief exemptions. We are not, that is not what our data has shown. This is a new thing. We have a right to question. We have a right to think about it. We have a right to want to, okay, let me think. That makes us informed consumers. That's not hesitance. And so we don't want to see vaccine hesitance used as an excuse to disregard serving us and to serve us poorly and say, oh, well, we couldn't really serve the Black folks because they were hesitant. And so that's what I mean by unhelpful narratives. And last but not least, partnering with trusted messengers and trusted partners, people who we all trust. That's who we go to receive services. That's who we go to get information. That's who we go to find out, well, should I do this? You know, that's real. And trusted messengers and trusted partners have to be really a part of this. Otherwise, we won't be successful in reaching the numbers that Dr. Aboelata and I have been talking about. So I'm going to conclude there because I know we have quite a few questions. And we
Well, thank you both. I think these were some really helpful insights. I've learned some things, and I'm sure I hope y'all listening along have learned some things. So I'm going to go ahead and dive into these questions so you all can provide your insight. First question we have here: is there any knowledge of the long-term effects of the vaccines?
Yes, that's a great question. I mean, I might just start answering this question by saying this has been a very challenging time in that we are having to make decisions quickly without all the information we would like. In a perfect world, I want 5 years of data. Give me 5 years of data, 2 years of data, something. We're not in that situation. That feels like a luxury right now that I wish we had. And so what we have is the length of time since the first, vaccines were administered. So we're almost at a year now. And for the vast majority of vaccines, just historically, if there's going to be adverse effects, they typically occur within the first 6 weeks. And so the last one that I remember was the